You wake up exhausted, you went to bed at a reasonable hour, you slept 7 or 8 hours, and you wake up feeling like you did not sleep at all. By 2 in the afternoon, your energy crashes, and you find yourself sitting in a chair wondering how you are supposed to get through the rest of the day. You used to be active, you used to have drive. Now everything takes more effort than it should, and the explanation you have been given, by your doctor, by everyone around you, by the entire cultural story we tell about getting older, is that this is just what aging feels like. I want to challenge that explanation directly, because for a significant proportion of seniors experiencing this exact pattern, the morning exhaustion, the afternoon crash, the effort that used to come naturally, the cause is not age. It is a specific, measurable, testable shift in the hormonal systems that regulate your energy, your metabolism, your sleep architecture, and your motivation. Systems that are not supposed to simply switch off with age. Systems that, when they fall out of balance, produce exactly the pattern I just described. And systems that, when properly investigated and addressed, can restore a level of energy and function that most people had written off as permanently gone. I am Dr. Edward. In this video, I am going to walk you through the 4 hormonal systems most commonly responsible for the fatigue pattern in seniors, the specific hormones involved, what they control, how they fall out of balance as we age, and what the measurable biological consequences look like in the body. I am going to show you the research on why this is so consistently misdiagnosed and dismissed. And I am going to tell you the exact tests you can ask your doctor for and the specific threshold values that distinguish a hormonal imbalance from the broad sweep of normal aging. Before we begin, what you are about to hear is educational information based on published scientific research. It is not a substitute for personalized medical care. Hormonal evaluation and any treatment decisions must happen in partnership with a qualified physician. If you are currently under any form of medical treatment, please do not make changes to your routine based on this video without first speaking to your doctor. And one quick thing, if this is your first time watching this channel, please subscribe right now. I publish this kind of research every single week, the science that your 10-minute appointment does not have time to explain. It is free and takes 2 seconds. Subscribe and let us get into this. Let me start with something that I think is fundamental to this entire conversation because it reframes the way most seniors think about their energy. The body does not have one energy system. It has several, and they work together in a coordinated network. Your thyroid regulates the metabolic rate of every cell in your body. It is the speedometer for your entire physiology. Your adrenal glands produce cortisol, the hormone that manages your stress response and your daily energy cycle. Your sex hormones, testosterone in men, estrogen and progesterone in women, play roles in muscle maintenance, mood, cognitive function, and sleep quality that most people never associate with those hormones. And your insulin sensitivity determines how efficiently your cells access glucose for fuel. When even one of these systems falls significantly out of balance, the result is fatigue. When 2 or 3 of them fall out of balance simultaneously, which is common in seniors, the fatigue can be profound, persistent, and completely resistant to the things that normally fix tiredness: sleep, rest, nutrition, exercise. What makes this so clinically difficult is that the symptoms of hormonal imbalance in each system are similar enough to each other and similar enough to the symptoms of normal aging that without targeted testing, it is nearly impossible to identify the cause from symptoms alone. Fatigue from thyroid dysfunction looks like fatigue from low testosterone, looks like fatigue from adrenal dysregulation, looks like fatigue from insulin resistance. The symptom is the same. The cause is different, and the treatment depends entirely on which system is out of balance. This is why so many seniors spend years being told they are simply aging, when what is actually happening is something far more specific and far more addressable. The first hormonal system to understand is the thyroid. Your thyroid gland, a small butterfly-shaped gland at the base of your throat, produces 2 hormones, thyroxine and triiodothyronine, which regulate the metabolic rate of essentially every cell in your body. Think of thyroid hormone as the throttle setting for your entire physiology. When thyroid output is optimal, cells generate energy efficiently, your temperature regulation works properly, your bowel moves at the right pace, your hair and nails grow normally, your mental processes are sharp, and your energy is available for the demands of the day. When thyroid output falls, a condition called hypothyroidism, every one of those processes slows down. Energy production at the cellular level becomes less efficient. The result is a fatigue that is not just tiredness. It is a heaviness, a slowness, a feeling of operating through resistance. It is accompanied by cold intolerance, constipation, dry skin, hair thinning, slowed reflexes, and a cognitive fog that many patients describe as the inability to hold a thought clearly. These symptoms develop slowly, over months or years, and each one individually can be attributed to aging. Together, they form a pattern that points unmistakably toward the thyroid, but only if someone is looking for the pattern. Hypothyroidism becomes significantly more common with age. Research from the Colorado Thyroid Disease Prevalence Study, which surveyed over 25,000 adults, found that approximately 10% of women over 65 and 3% of men over 65 have clinically significant hypothyroidism. More importantly, an additional 16% of adults over 65 have what is called subclinical hypothyroidism, thyroid function that falls within the laboratory reference range, but at the low end, producing symptoms that are real and measurable, but that most standard screenings would classify as normal. This distinction between subclinical and clinical hypothyroidism is one of the most contested and most clinically important debates in endocrinology, and I want to spend a moment on it because it directly affects the test result interpretation that your doctor will give you. The standard thyroid test measures TSH, thyroid-stimulating hormone. TSH is a signal released by the pituitary gland that tells the thyroid to produce more hormone. When thyroid output is low, TSH rises as the pituitary pushes harder. Most laboratories flag TSH values above 4.5 millunits per liter as abnormal, but research, including a landmark analysis published in the Archives of Internal Medicine, found that the 97.5th percentile of TSH in a healthy population without thyroid disease or risk factors is 2.5 millunits per liter, significantly below the standard cutoff. This means that a patient whose TSH is 3.8, technically within the laboratory normal range, may be experiencing the full symptomatic picture of hypothyroidism, and a doctor relying solely on whether the number falls inside the reference range will tell them their thyroid is fine. This is why the conversation with your doctor needs to go beyond a single number. If you are experiencing the fatigue pattern I described, you should ask specifically for a full thyroid panel. Not just TSH, but also free T4, free T3, and thyroid antibodies. The antibody test identifies Hashimoto thyroiditis, an autoimmune condition that is the most common cause of hypothyroidism, and that can produce significant symptoms at TSH levels that standard ranges would consider normal. And you should ask your doctor to interpret your results in the context of your symptoms, not simply whether the number falls inside a reference range designed for a population that includes people 20 years younger than you. If you want to make sure you get the follow-up video where I walk through what optimal thyroid levels actually look like and how to prepare for this conversation with your doctor, subscribe right now. That video is coming and you will want to see it before your next lab appointment. The second hormonal system is cortisol and the HPA axis, the hypothalamic pituitary adrenal axis that governs your stress response and your daily energy rhythm. Cortisol is produced by your adrenal glands and operates on a diurnal cycle. It peaks in the first hour after waking, giving you the physiological push that gets you out of bed and functioning in the morning, then gradually declines through the day, reaching its lowest point late at night to allow sleep. This curve, high in the morning, low at night, is essential for energy regulation, immune function, blood sugar control, and sleep quality. It is one of the most important rhythms in human physiology. In seniors, this curve frequently becomes dysregulated. The morning peak flattens. Cortisol does not rise adequately after waking, which means the physiological energy push does not occur. The person wakes up feeling as though they have been awake for hours already, without the hormonal momentum that would normally drive morning activity. Simultaneously, cortisol often fails to drop appropriately in the evening. It remains elevated when it should be declining, which disrupts the onset of deep sleep, reduces growth hormone release during sleep, and produces the shallow, unrestorative sleep that seniors frequently describe as lying in bed for 8 hours and waking up unrested. This pattern, blunted morning cortisol with elevated evening cortisol, has a specific clinical name: HPA axis dysregulation, sometimes called adrenal fatigue in popular medicine, though that term is technically imprecise. A study published in the journal Psychoneuroendocrinology measured the cortisol awakening response in 487 adults across 4 age groups. Adults over 65 showed significantly blunted cortisol awakening responses compared to younger adults, and the degree of blunting correlated directly with self-reported fatigue severity, cognitive complaints, and sleep quality measures. The cortisol curve was not just a marker, it was a predictor. The flatter the morning rise, the worse the fatigue. Chronic psychological stress is one of the most powerful drivers of HPA dysregulation, and seniors carry an enormous and often unacknowledged psychological stress burden: loss of spouse, loss of peers, financial uncertainty, reduced physical capacity, chronic pain, social isolation. These are not small stressors. They are major ongoing physiological stressors that activate the HPA axis chronically, exhaust its capacity for appropriate diurnal variation, and produce exactly the dysregulated cortisol curve I described. The fatigue is not weakness. It is the downstream consequence of a biological system that has been under sustained load for years. The test for this system is not a simple blood draw. A single blood cortisol measurement is nearly meaningless because it tells you nothing about the diurnal curve. The appropriate test is a 4-point salivary cortisol, saliva samples collected at waking, mid-morning, early afternoon, and bedtime, which maps the full daily curve and identifies whether the morning peak is adequate and whether the evening decline is occurring appropriately. This test is available through functional medicine practitioners and some integrative endocrinologists, and it provides information that standard blood cortisol testing simply cannot. Now, there is something I want to be clear about in the context of cortisol and fatigue, because there is significant misinformation in the supplement industry around this topic. Adrenal support supplements, the category of products marketed to correct adrenal fatigue, are largely unsupported by clinical evidence. Some contain adaptogenic herbs like ashwagandha and rhodiola that have genuine research backing for stress response modulation, but the products marketed specifically as adrenal support are a mixed bag at best. The interventions with the strongest evidence for improving HPA axis function are behavioral and lifestyle-based: consistent sleep and wake timing, regular moderate-intensity aerobic exercise, evidence-based stress reduction practices, and strategic dietary patterns that support stable blood glucose. These are not glamorous recommendations. They are the ones that work. Now, if you are finding this useful and you know someone in your life, a spouse, a parent, a sibling, who has been dismissing their fatigue as just getting old, I want to ask you to share this video with them before it ends. Not because the information is alarming, but because it offers an alternative explanation that most people have never been given. And if you are not already subscribed, please do that now. This is the kind of research that changes the conversations people have with their doctors. The third hormonal system is sex hormones, and this is the one I want to spend the most time on because it is the one where the gap between what the research shows and what most seniors are told is widest. In men, testosterone production begins declining at approximately 1% per year from around age 30. By age 65, the average man has lost between 30 and 40% of his peak testosterone production. But this average conceals enormous individual variation. Some men maintain robust testosterone levels into their 70s and 80s. Others experience a decline that begins earlier and progresses faster. The men who fall into the lower range, what endocrinologists call late-onset hypogonadism, experience a clinical picture that is almost universally attributed to aging rather than to the hormonal change driving it. fatigue, reduced muscle mass and strength, increased abdominal adiposity, reduced motivation and drive, cognitive slowing, disrupted sleep, and in many cases, a low-grade depression that does not respond well to antidepressants because the underlying cause is hormonal rather than psychiatric. A study published in the Journal of Clinical Endocrinology and Metabolism followed 2,100 men over 65 and measured testosterone levels alongside quality of life metrics. Men in the lowest testosterone quartile reported fatigue at rates 2.4 times higher than men in the highest quartile, independent of age, BMI, and comorbidities. The testosterone was not just a correlate, it was an independent predictor of fatigue severity. And critically, men in this study whose testosterone levels were in the low normal range, technically inside the reference range, but at the bottom of it, reported fatigue profiles virtually identical to those with clearly deficient levels. The laboratory threshold for deficiency does not correspond to the symptom threshold. In women, the hormonal picture is more complex because menopause involves the loss of both estrogen and progesterone, and these two hormones have distinct effects on energy and sleep. Estrogen plays a role in serotonin and dopamine signaling. It supports mood stability and cognitive energy. The sharp decline in estrogen at menopause is directly associated with the mood disruption, cognitive fog, and motivational changes that many postmenopausal women experience. But it is the loss of progesterone that most powerfully disrupts sleep. Progesterone has a direct calming, sleep-promoting effect through its action on GABA receptors in the brain. It is structurally similar to some sedative compounds and produces a mild anxiolytic and hypnotic effect. When progesterone falls at menopause, the quality of sleep changes. The deep, slow-wave sleep phases become shorter, sleep is more fragmented, and the restorative repair that occurs specifically during deep sleep is reduced. A woman sleeping 8 hours after menopause may be getting 40% less restorative sleep than the same woman sleeping 8 hours before menopause, simply because the progesterone that was deepening her sleep is no longer present. The tests that matter here are total and free testosterone for men, because free testosterone, the biologically active fraction, can be low even when total testosterone appears adequate due to age-related increases in sex hormone-binding globulin. For women, estradiol, progesterone, and FSH are the relevant markers, interpreted in the context of where the woman is in her menopause transition. These tests are straightforward and widely available. The issue is not access. It is whether the conversation that leads to them is happening. The fourth system is insulin sensitivity, and I include it in a conversation about hormonal fatigue because insulin is a hormone, one that most people associate only with diabetes, and its dysregulation produces a fatigue pattern that is among the most common and most misidentified in the senior population. As we age, the sensitivity of our cells to insulin decreases. This is driven by a combination of factors. Declining muscle mass, which is the primary site of glucose uptake in the body, increased visceral adiposity, which releases inflammatory signals that directly impair insulin receptor function, reduced physical activity, and the cumulative effects of decades of dietary patterns that have stressed the insulin response system. The result is what clinicians call insulin resistance, a state in which normal amounts of insulin are no longer sufficient to drive glucose efficiently into cells for energy production. The cellular consequence of insulin resistance is that despite adequate blood glucose, cells cannot access that glucose efficiently. They are fuel-starved in the presence of fuel. The fatigue this produces is particularly pronounced after meals. The post-lunch energy crash that many seniors experience is a direct consequence of the insulin surge triggered by a carbohydrate-heavy meal overwhelming a resistant system, causing a reactive drop in available cellular energy. Despite blood glucose remaining elevated, the person is simultaneously running high blood sugar and experiencing cellular fuel deprivation. This is one of the most underappreciated mechanisms of senior fatigue. The standard test for insulin resistance, a fasting glucose measurement, misses a significant proportion of cases. Fasting glucose can remain normal for years, while post-meal insulin and glucose dysregulation is already causing significant metabolic stress. The more informative tests are fasting insulin, a 2-hour post-glucose challenge insulin level, and hemoglobin A1C, the 3-month average of blood glucose. Together, these give a picture of metabolic health that a single fasting glucose measurement cannot. Here is what the research consistently shows about addressing insulin resistance in seniors. The single most effective intervention is resistance exercise, strength training that rebuilds and activates muscle tissue, which acts as a glucose sink and restores insulin sensitivity at the cellular level. A meta-analysis published in Diabetes Care analyzed 23 randomized controlled trials of resistance training in adults over 60. Across all trials, regular resistance exercise reduced fasting insulin levels by an average of 25% and improved post-meal glucose regulation significantly. 2 to 3 sessions per week of moderate resistance training, bodyweight exercises, light weights, resistance bands, produced these effects within 8 to 12 weeks. Not months of intensive gym work, 8 weeks of consistent, moderate effort. Before I give you the summary and the action steps, I want to say something that I think matters. The narrative of aging in our culture is one of inevitable, irreversible decline. We are told that the fatigue, the mental fog, the loss of drive are simply the price of getting older, and that acceptance is the only appropriate response. I think that narrative is doing enormous harm to seniors whose fatigue has a specific, addressable biological cause, and who spend years accepting a diminished quality of life because they were told it was normal when it was not. I am not telling you that hormonal imbalance is the explanation for every case of senior fatigue. I am telling you that it is the explanation for a significant proportion of them, and that the only way to know whether it applies to you is to ask the right questions and get the right tests. Your fatigue deserves an investigation, not a dismissal. Here are the specific tests worth requesting in a conversation with your doctor. For thyroid, TSH, free T4, free T3, and thyroid antibodies, anti-TPO, and anti-thyroglobulin. For the cortisol system, a 4-point salivary cortisol test, if accessible, or at minimum, a morning serum cortisol measured within 60 minutes of waking. For sex hormones, in men, total and free testosterone with sex hormone binding globulin. In women, estradiol, progesterone, and FSH. For metabolic health, fasting glucose, fasting insulin, and hemoglobin A1C. When you make this appointment, use these words: I have been experiencing persistent fatigue that is not improving with adequate sleep, and I would like a full hormonal workup. Those words signal to your doctor that you are looking for a specific investigation, not a general wellness check. They change the conversation, and when you get your results back, do not just accept that your numbers are normal if your symptoms are not. Ask specifically where in the reference range your values fall. Ask whether subclinical findings in any of these systems could be contributing to your fatigue. Ask for a second opinion from an endocrinologist or a functional medicine physician if your concerns are not being addressed. You are not being difficult. You are being an informed patient, which is exactly what this channel is designed to help you be. Here is the summary of what we covered. Persistent fatigue in seniors is frequently not simply a consequence of aging. It is a consequence of measurable imbalances in the thyroid, the HPA axis, the sex hormones, or insulin sensitivity, or a combination of these systems. Each imbalance has a specific biological mechanism, a specific symptom signature, and a specific set of tests that can identify it. The standard workup most seniors receive does not include these tests unless they are specifically requested. Subclinical findings, values within reference ranges but at the low end, can produce significant symptoms and deserve clinical attention in the context of a symptomatic patient. The interventions that address these systems include targeted medical treatment in some cases and evidence-based lifestyle modification in others, and those decisions belong in a conversation with a physician who is engaged and informed. If this video gave you language, gave you a framework, gave you a reason to pick up the phone and make an appointment you have been putting off, that is what it was for. Please share it with every senior in your life who has been accepting fatigue as inevitable, and subscribe to this channel. My next video covers the specific dietary pattern that supports hormonal balance in seniors, the nutrients, the timing, and the foods that clinical research has shown to support thyroid function, cortisol regulation, and insulin sensitivity simultaneously. That is the practical companion to everything I told you today. Subscribe so it reaches you directly. I am Dr. Edward. Your fatigue deserves an answer, not an acceptance. I will see you in the next one.